Welcome everyone to the first seminar of IANPHI African Network, which we have organized, of course, in collaboration with IANPHI Secretariat and colleagues around Africa. So I want to take this opportunity to welcome all of you to this very seminar, which is actually one important seminar where we shall reflect on how far we have come as Africa in terms of development of national public health institutes. You all know that we are in different stages of development of national public health institutes in Africa. We have very old institutions and we have new institutions. And we also have institutions that are in the process of being formed. Now, in the process of doing this, we've gone through a lot. We've learned a lot of experiences. We have also used very many instruments, including national public health development frameworks, legal frameworks, the state development tool, and many others. And so to enable us actually do all these, we have interacted with many stakeholders. We've been supported by many stakeholders in terms of technical and financial support. So now that we have institutes that have actually matured in the process, and we have also had a number that have learned what has happened in the process, we would like to share all this with members of the network and beyond. And so we managed to organize this seminar, whose topic is the rise of African national public health institutes and lessons learned from stakeholder involvement in their operationalization. And so to help us discuss this and understand it a little bit more, we have Dr. Nathalie Mayette, the immediate past president of the IANPHI African Network. And she is also the deputy director of the National Institute for Communicable Diseases of South Africa. We also have Professor Roma Chilengi, one of the newest directors, I could say. Professor Roma joined us not so long ago, and he is the director of the Zambia National Public Health Institute. Quite an experienced person, and I would like to listen a little bit more from him. And then we have Hafton Tame Desta, who is the principal technical officer, National Public Health Institutes in Africa Centers for Disease Control and Prevention. Now, these are people I've interacted quite closely with, and they are very experienced persons in terms of development of national public health institutes. And I believe we are going to learn a lot from them and cross-fertilize what we have all come up with in terms of formation and maturation of national public health institutes in Africa. So without much ado, let me welcome Dr. Nathalie Mayette to actually take the floor. Nathalie?
Thank you, Dr. Alex. Good greetings, colleagues. Good morning, good evening, good afternoon. Welcome, and thank you to IANPHI and IANPHI African Network for inviting me to share some of our lessons learned from stakeholder involvement in this journey. Could I have the next slide, please? So if we look at the science and public health institutes based in science, it defines complexity from the Latin word complexus. And certainly to say that we are living in a VUCA world with volatility, uncertainty, complexity, and ambiguity is an understatement. But what does this word mean? The COM, the com, means together. And the plectera is to wave or brand. And if you envisage a Mexican wave in a sports event, it's everybody moving together in synchronization. So it's how we are connected with each other and how these interactions work together. So if you look at the next slide, please, the core institutional logic shifts that we have learned during the time of COVID, and as we advance as an institution, it is essential that we increase our external focus. So we actually developing the core functions of a public health institution, but at the same time, expanding and increasing that external focus and interaction. So we move to a greater openness and focus on enabling interactions. But what I think we haven't done very well, which is something that we may need to engage further, is adopting interaction-centric metrics as public health institutions. So as we mature and as we adopt our strategies, there may be multiple tensions and institutional conflicts that don't align with each other. And these are lessons that we need to learn as we proceed. Next slide, please. So we see, and the science informs us, that national public health institutes are seen and deemed to be that dot. So if you take each public health institution, our central position within our member states offers the opportunity for us to tap into many different audiences, for us to be bridge connectors. So we are really key and central to network communication. And more importantly, we bridge connectors of other bridge connection networks. You see the blue line in the middle there. Next slide, please. And so ultimately, this is who we want to be. This is the center or the area of influence that we could have the potential as public health networks, as this matrix. But this is grounded certainly on trust relationships. And those trust relationships center around people. It centers around, firstly, initiating, secondly, about maintaining, and thirdly, around sustaining those trust relationships. Next one, please. So what we've learned in our public health institution in South Africa, when we established our genomic surveillance capability, we did it as part of a network, an extensive network. And this slide just demonstrates the range of interactions that we've had with multiple stakeholders across academia. Next slide, please. Across communities of scientists, across institutions. Next slide, please. And as we move along, the networks across partners, donors, the supranational institutes like Africa CDC, US CDC. Next slide. The private sector, and the list goes on and on and on. And it's really very, very difficult to narrow and to focus on one specific network that was more influential than the other. And if you look at that Mexican wave, we moved together and we focused on developing and formulating our common agenda and our vision of what we collectively wanted to achieve. Next slide. We did not have all the resources available. And I don't think any of our public health institutions are adequately resourced to deal with the challenges that we face on the continent. So we developed a consortium. We have one modeler in our institution, and he formed and facilitated the establishment of the South African Modeling Consortium. And the work that was produced collectively with this team brought experience, expertise, different perspectives to be able to guide the country in producing models, options of which those models could be delivered in dealing with the COVID, specifically with the COVID outbreak. And now they're modeling the impact of COVID on other diseases like TB and HIV. Next slide, please. Obviously, our stakeholder communication tools are essential, and many public health institutions have a range of tools. But what we did learn, certainly, that we needed to start streamlining the multiple social media tools to be able to generate analytics. And we've done that through a tool called MailChimp. We're also working with our colleagues from USCDC and learning quite extensively how to establish a public health bulletin. And Alex, congratulations on your public health bulletin. It's always a pleasure to review that when it's shared. And importantly, as a public health institute, when we produce and our outputs need to focus on our scientific publications, our policy briefs, but also on data, focusing on that data to policy brief. Because we often forget that that data to policy is a key tool to influence in our broader network of policymakers. Our stakeholder communication tools as well need to speak to the communities that we serve. And often our learnings have taught us that the tools that we use were largely science-based, and some of the terms and the words that we use did not connect with local communities. There was no word for coronavirus in any one of our 11 languages locally. So we've got a lot of work to do in terms of tweaking our stakeholder communication tools to be locally relevant and to be influential in a way that it speaks to the target audience. And certainly the Public Health Bulletin, modeled on the US CDC public health outputs, is certainly something that we can aspire to. And I think we're all in development of that. The Twitter feeds and the Facebook feeds and the social media interaction is something that we've used as a listening platform. And often, as public health institutes, our information flows from the institutes downwards. But we need to start creating bi-directional flows of communication for us to enhance our stakeholder engagement. And I think that is something that is work in progress for many of us. So as a way forward, next slide, please. Our suggestion is that we involve communities and we strengthen our event-based surveillance, but focus specifically on those marginalized communities that we've not really engaged with extensively in terms of design, surveillance activities, research activities, and implementation of interventions. So our event-based surveillance for public health institutions and the networking in local communities with traditional healers, with caregivers is something that I think is an opportunity for us to move forward. We need to leverage off our collective network platforms. So each of our member states has got a network platform, extensive, but we need to leverage on those network platforms to create our common vision for the continent. There's something called digitized socialism. The power of the collective is a tool that we need to harness and switch from ownership to curatorship. So we need to develop those tracking tools that will be 1,000 times more powerful than just individual work that each of our respective institutes are involved in. And we need to focus on our convener capital. And that we're doing with this webinar is certainly one of those tools that enhance our convener capital. We need to focus on our convergence of man and machine. We all have epidemiologists, some of us have more than others, but how do we link our epidemiology, limited epidemiology capacity with artificial learning and enhancing our networking capability? I think what we mustn't forget is involvement of the teams within our national public health institutes and building that leadership capacity within our respective institutions to influence with speed and direction, to encourage creativity, to harness the capacity of diversity within our national public health institutions and across the continents, and to encourage diverse decision-making. But to do that with calm, with precision, with intent, and to think globally, but act locally. Next slide, please. I would like to acknowledge and thank our network matrix that's extensive. And certainly I always fear to put in an acknowledgement slide in case we've left out critical and key stakeholders. So that's not the intention, but it's to acknowledge the people who we serve that drive our agenda and who we need to really drive our network engagement with. Thank you.
Thank you so much, Natalie, for that wonderful presentation, which was loaded with a lot of novel information, but also, sending the experiences learned during COVID and during other times. I know the formation of the South African COVID-19 Modeling Consortium is one of the best things that have happened in Africa during COVID. I know there's a lot that we have to learn. And I think you mentioned it in your closure, that we need to leverage on the capacity we have in national public health institutes. Because we do have a lot. We have a lot in terms of data analytics. We have very wonderful epidemiologists known all over the world. We have a very good laboratories. And I think there's a lot that we can learn from ourselves. And one thing you mentioned there about digitized socialism. These are some new, innovations that can bring all of us together. So I think we need to really think global and not local, as you say. We need to harness amongst ourselves within Africa. And I think we learned a lot from the world, but it is now time for us to show it as Africa. So thank you very much, Natalie. I would urge the audience, if there are questions, please post it on the chat. But if you want to talk, then you wait until the end, because we still have many more presentations. So let me welcome Professor Roma Chilengi. Professor Roma, are you there?
I'm here, thank you. Can you hear me?
We can hear you well and clear. So please proceed with your presentation.
Thank you so much. And it's such a pleasure to have Natalie open the presentation with such a high level pitch. We truly appreciate your work, Natalie, and you just have a great gift of expression. So thank you very much for setting the stage. I will get into the Zambian presentation, I think consistent with what the theme of the webinar is. We want to give the case of Zambia. I think you will find that Zambia in many respects is a young public health institute. And so our story is really not as full of accolades, but I think it's one worth telling. Thank you so much. I realize that a lot of people who are outside Africa may not know where Zambia is. So Zambia is in the south central of Africa, and we have a population of just over 18 million. And it is, we call it land-linked with 8 neighbors and 1 by sea. And we have a GDP of just about 19 billion, and per capita is just over 1,000. So that introduction, I hope, gives context of the status of Zambia. Next slide, please. So the Public Health Institute was really conceived in about 2015 as a unit under the Directorate of Public Health in Ministry of Health. And this really was, the initiative was supported by US CDC, which provided seed funding for the establishment of the institute. And following a policy decision to operationalize the African Union resolution, which created the Africa CDC and its three-tier operational model, the institute was earmarked to become a statutory body under the government of Zambia. And this is 2015. Next slide. So the establishment of the ZNPHI gives it the vision to be a center of excellence in public health security for a healthy Zambia. And also to the mission is to really coordinate public health security in Zambia by ensuring robust surveillance systems, effective preparedness and emergency response mechanisms to support evidence-based decision-making in the space of public health. And so our institute exists as a specialized arm of government to provide that public health security. And on top of that, the institute is designated as host to the Africa CDC Regional Collaborating Center for Southern Africa, representing 10 member states in the Southern African region. Next slide. So really, we exist to provide assurance that Zambia's public health security is in check in the wake of continued public health threats and events. And we anchor effective fulfillment of the vital regional and international obligations. And also we align the global best practice and provide international confidence including among donors and cooperating partners in the space of public health and health security. Next slide. So really, this timeline tells a summary of where we are coming from 2010 to the present moment. I think a few key things of note. 2009, we had a very massive cholera outbreak in Zambia. 2013, 2014, I think we all recall the Ebola outbreak. I think the Ebola outbreak was a key trigger to conversations around conception of the Institute. And from 2017, really, Zambia was assigned to host the RCC, the Regional Collaborating Center, and the Institute was actually conceived and formed. Now, it took several years before the Act of Parliament was passed, and then the Act getting operationalized really with a commencement order only in April 2021. And so as of March 2022, that's when the Institute was now set as a statutory body standing by itself, governed by a board of directors, and given establishment of its own fiduciary functions and administrative obligations. And shortly following that, I think that it is important for us to highlight what we call the Lusaka Declaration, which was led by the President of the Republic of Zambia, calling on other presidents in the region to set up functional public health emergency operating centers in July 2022. And so thus far we have come as an institute and setting stage to dealing with health security in Zambia. Next slide. Briefly, we are set up as governed by the board under the Ministry of Health, and we have basically 5 key strategic clusters. one cluster that focuses on surveillance and disease intelligence. The other cluster focuses on emergency preparedness and response. Then we have the National Public Health and Laboratories Systems and Network. And we have Strategic Information Management cluster that harnesses all the information together, try to make sense of it, generate the public health communication, both for the public at large, as well as for the sort of scientific and professional communities. And then we also have the Health Workforce Development cluster that really deals with the issue of preparing staff, the training that we need to have a prepared health workforce. Next slide, please. So we have made quite a bit of progress in light of our mandate and with a new structure that I've just alluded to. I think in the past 1 year almost now, we've had a functional board in place. We have board subcommittees. We have a subcommittee on finance, and we have a subcommittee on HR. We have a subcommittee on technical aspects, and we have a subcommittee on audits. So our governance structure is organized to meet quarterly and can also meet ad hoc, basically to provide that governance oversight to the institute. So as Director General now, I report directly into the chair of the board, and this is how we are set. I think it's important to highlight that with that setup, we have the privilege of being on the budget of the national on the national budget and receive direct funding from the ministry, from the government of Zambia through the Ministry of Health, and therefore deal with our operational and other costs as it were. I think that we've made a lot of progress in the public health security management within the institute, and we've provided a lot of training for various aspects that have to do with the identification of threats and hazards, preparedness for dealing with emergencies, and specific case management training and preparedness for the imminent and present threats that we are faced with. So as an institute, we coordinate a lot of these activities among stakeholders and funders. And most importantly, we are actively setting up a public health emergency operations system and an incident management system that is basically dealing on the health events as we face them. I think it is important to highlight in our context that a multi-sectoral mechanism is incredibly important for public health, because our public health system is being born out of a health system that is very much tuned to curative and treatment services. So the whole notion around taking public health really to problems before they happen is one that we are working hard to set, and is one that requires us to engage a lot with a multi-sectoral mechanism within the country. And I'll speak to that again in a bit. Next slide, please. Yes, so we have been privileged to have substantial resources really secured by the government of Zambia through a World Bank loan that are assisting us and will continue to assist us to meet the strategic intentions and the missions of the institute in terms of our operations, in terms of the key staff that we need, and in terms of the buildings and the facilities, but also the laboratory systems and networks. We have done a lot of work in providing public health security management, and we are working at subnational level trainings. And I think our field epidemiology program which recently received accreditation from AFINET, is going on well. And as we speak at the moment, the advanced FETP program does host international students as well. We have students from Malawi, students from Lesotho, and we hope that moving to the future, we will be able to have students representing the entire sub-region to reinforce the fact that we are coordinating the sub-region office. We also have quite a few activities that are focused on the One Health issue. And as you would imagine, the One Health issue does require a very broad multi-sectoral setting, but predominantly with the livestock and fisheries ministry, the environment ministry, as well as the sector that deals with water and sanitation. We engage very closely with those sectors. We are also the secretariat for the antimicrobial resistance activities in country, and that again takes a One Health approach. And so we are co-chairs with our counterparts from livestock ministry, coordinating activities of antimicrobial stewardship, and also trying to track emergency of antimicrobial resistance as part of the stewardship activity. We've done the threats and hazards identification, risk assessment in country, and shortly we should be disseminating the finding of the thyra activity in Zambia. And we have the first dedicated public health laboratory set up and equipped, and looking forward to basically spreading the network of other. Next slide, please. Next slide. Next slide. Hello. Next slide. Okay, so I think that to share a few best practices from our experience so far, I think that I alluded to the issue of having coordinated multi-sectoral approach. It's incredibly important, especially in times like this, that we are battling multiple disasters. So in the way we are set up, there is the National Disaster Management and Mitigation Unit, with whom we work very closely when those disasters interface with health and public health. And so in that regard, there are a number of activities that we are continuously engaged in. I already talked about the One Health approach, but I think that for ourselves and colleagues in the region, obviously as Public Health Institute, we need to have a lot of resource mobilization activities so that we can support the evolution and desired structures and systems of our public health institutes, given that most of our governments will not be able to fund full-time everything that goes with that health security mandate. So the mantle of resource mobilization is critical. And to do that effectively, I think that we need to have appropriately thought strategic plans that are approved and that we use basically to negotiate with partners and counterparts on strategies that may require support, that may require funding as we move forward. Next slide, please. So some pictures are from as recent as last week. Basically, the challenges of public health require that we take the activities to the grassroots, and some of the people that we are supposed to serve are first in communities and places which are very hard to reach. And the images here refer to our field activity last week when we are following up on a cholera outbreak right at the border of Zambia to Malawi, where our communities and populations are so sparse and very hard to reach in many instances, but that's where the outbreak is. So we have to take public health security to them. And we were busy basically with messaging, with chlorine distribution, with awareness promotion, but also administration of oral cholera vaccines. So we need to have really appropriate legislation that provides support for basically accumulation of public health emergency operation center funding. In our case, we are in the process of really seeking specific approval that we may have a FIOC support that is dedicated as a public health resource dedicated for that purpose. We have challenges also with the subnational structures. At the moment, in the way we are set and conceived, we have a fairly robust and growing national level institute, but subnationally, we have to work with existing systems within the Ministry of Health, and in a ministry that is already stretched. Sometimes we have challenges where certain surveillance information may not be prioritized given what is happening in that particular context. So being very donor supported and dependent obviously brings the challenge of sustainability to our programs. So even as we set up programs and activities, we always must answer that question of sustainability. And sometimes our mandate really overlaps with mandates of other institutions like vaccination activities, water and sanitation issues, then the issue of port of entry and how to manage and mitigate against disease across border issues. Sometimes the mandate overlaps, and so it becomes a bit gray whose responsibility that is, and we have to manage that diplomatically. Data synchronization and utilization is another challenge we are faced with, and we are actually trying to work very hard to come up with a sort of centralized data system that puts together various data sources so that in one place one can answer any question related to public health security. At the moment, data sets for COVID numbers sits somewhere, the vaccination sits elsewhere, you know, either outbreaks. So we are hoping to bring all these into the FIOC and be able to manage them. Next slide. Looking to the future.
Please summarize.
It's actually my last slide. Looking to the future, I said we are privileged to have funding that will support establishment of our home, permanent home as an institute. And the image there are some of the models which will be the future house of the Zambia National Public Health Institute, and groundbreaking just happened. And so a lot of construction activity going on. Next slide. Some highlights from the high-level activities with the president championing the FIOC. We had a recent visit by the Secretary to the Treasury from the US, Minister of Health, our activities at the Public Health Conference. And by the way, we'll be the hosts for the next Africa Public Health Conference here in Zambia. Next slide, please. Activities from the field, and last slide, to acknowledge our partners and funders that we work with. That slide is summarizing it all. Thank you so much.
Thank you so much, Prof. Chilengi. I think you've highlighted quite well. There are a lot of similarities in, thank you first of all for the milestones that you have achieved at Zambia National Public Health Institute. It has not been easy. And I think the experience you have shared, cuts across many institutions in Africa. It has not been easy for us. The lengthy process of legislation, just as you've mentioned. Much as everybody thought now Zambia had wound it up all, but you still had to go another mile, to get the process completed. And there are many challenges that you mentioned, including donor dependency. I'm happy that you want to set up the Public Health Emergency Fund. We are similarly advocating for that. And I think that needs to cut across Africa, because if we want to break, the chain of donor dependency, we need to ensure that we have enough domestic funding. No question about that. And then, of course, having a permanent home is not only going to increase your visibility, but it's going to make everybody recognize you now as an entity. So thank you so much, Prof. Silengi. May I now call upon Hafton Tame to wrap it up all. Hafton is now going to talk about the overall African experience based on the data that we've looked at over time. Hafton?
Thank you, Dr. Alex. I would like to thank IANPHI African Network for organizing this meeting or this webinar and inviting Africa CDC to give a brief update on the status of NPHI development across the continent. If you can share the slide from your side. Yes, so I will focus on findings of two studies. From Africa CDC side, we conducted one online survey that includes the directors of NPHIs across the continent and focal persons of NPHIs. And secondly, we also conducted a comprehensive desktop assessment because the response rate was not complete during the survey, the online survey. So I will be presenting a major findings of the studies. Fortunately, Dr. Alex and Dr. Natalie were part of the write-up of the article, which is published in the Fortune Journal of Health Sciences. So I will be focusing on the findings of this one, and later on the descriptive assessment, which is one slide. Okay, next. Yeah, so the first thing that we did for Africa CDC, of course, in collaboration with IANPHI, is to standardize the definition of National Public Health Institute. So for us, we try to standardize it, and we also try to define the different models of NPHIs existing in Africa. Actually, it's common across the globe. So we are looking to 3 models of NPHIs. And for information, the definition for the 2, because sometimes people do not understand what is a single institution or the autonomous institution, and what is a network of institution. So we define the autonomous or semi-autonomous National Public Health Institute as a single institution, which is established by a legal framework to coordinate public health functions at national level. And we define that the National Public Health Institute should have a minimum of functions, mandates, at least a minimum of these 5 core mandates. It should have, a mandate to conduct disease surveillance and intelligence. It should have a laboratory diagnosis and systems, and it should have a mandate for emergency preparedness and response, and to conduct public health research. So these are the minimum 4 functions that a National Public Health Institution should have. Then the network of institution will be the same, but again, it will have a legal framework to coordinate these public health functions at national level, but the core functions may fall or be conducted by different parastatal institutions at a national level. So when you see the difference between these 2 categories of institution is, in a network of institution, the public health functions for the network of institution fall into more than 1 operationally and technically independent institution. That's why we're just following different models of NPHIs for different countries based on their national context. And of course, the third one is a department under the Ministry of Health, given to coordinate the minimum core functions we mentioned. Next. Yeah, so from the online survey, which was self-administered by the directors of NPHIs and FOCA persons, we sent it to all the 55 member states, and 72 or 73% of these NPHIs responded, which is a total of 40 member states. So according to the definition we saw earlier, only 12 of the 14 member states have a fully established NPHIs. Fully established means we said that the minimum core functions, they have a legal framework and they are organized at national level. And there are around 17 countries which are in the process of establishing the NPHI. They are on advanced level of development, which means that they have already developed, or they are developing the legal framework, but the legal framework still has not been endorsed by the country's legal body or the legislative body, either the parliament or the cabinet or the president. And also there are around 6 countries which started the process to establish the NPHI. And during our survey, the survey was conducted from August 2021 up to May 2022. So up to this time, there were 5 countries among the 14 countries responded to our survey that they have not started any process to establish the NPHI. Next. Yes, so as I mentioned, we're looking to the legal frameworks, the legislative tools in the different NPHIs, especially on the 29 NPHIs which are fully established or in the advanced stage of development. 12 of the legislative documents were established, or the NPHIs were established by the Act of Parliament, and 12 of them were endorsed or established by presidential decree, and 5 were endorsed by the ministerial decree or established by the ministerial decree. So these are the list of the countries which are in the 3 category of the legislative tools. Next. Then looking to the different models that we mentioned earlier, 17 of the 29 member states or the NPHIs were established or are in the process of to be established as autonomous and semi-autonomous institutions. 4 of them are networks of institutions, and the rest 8 are established as a department under the Ministry of Health of these member states. And of these well-established and developing stage NPHIs, 19 have a strategic plan, partially funded by governments, and the government appropriation is on average of 40% of the annual budget of the NPHI. But of course, the allocation varies from country to country, which ranges from 1%, which the government covers 1% of the overall annual budget of the NPHI. And in some countries, 95% of the budget is covered by the government. Next slide. Then looking to the major functions given to these NPHIs as a mandate or conducted by these NPHIs. 26 of the NPHIs have a research or they are conducting public health research. 24 of them have a surveillance and disease intelligence activities. 24 also have the epidemic preparedness and response activities. And 19 are like having or conducting a workforce development. And 15 have the mandate to conduct this or to for the public health informatics or information system. And 10 member states have also NPHIs with a mandate for health promotion. Next slide. Then looking to the above findings were from the online survey administered by the directors of NPHIs, and we conducted a second assessment which includes all the 55 member states. Of course, we did this one by hiring senior consultants, especially for the 4 regions of Africa. And we try to look, again, through this assessment, online assessment, the development stage of these NPHIs. And from this descriptive assessment, we found it's more or less similar to the online survey, in which 35% of the assessed 55 members have established NPHIs. And 21 have no NPHI, but are in the process of establishing one. And 15 of these members have no NPHI and have not started any interest or planning to develop one. So looking to the plan, the strategic plan, only 9 of the 19 established NPHIs have a current strategic plan. Maybe they could have a strategic plan, but it's not accessible on the online system or the websites or any other sources that we could find. And only 13 of the 19 fully established NPHIs have a legal framework that we can access online, or the establishment is legal framework. And looking this by regions, we can see we need to do a lot on the Central Africa region. According to our standard or definition, only Burundi had a fully established NPHI. Of course, DRC and Chad are in the process of establishing one. And we can see that around 27% or 15 members have no plan, or they haven't started establishing NPHI. So this needs a very thorough support to these member states, maybe advocacies and visits both by the Africa CDC, IANPHI, and other partners, so that this country can start establishing NPHIs. Next slide. So this is the last slide, which is basically a key recommendation or steps from our side, from Africa CDC, for a country or member states which are planning to establish a national public health institute. One thing is to review existing public health actors that can support the establishment of national public health institute. Secondly, there is a need to secure a political buy-in for the development of the National Public Health Institute, and existing tools from the African Union and other declarations can be used as a supportive tool to convince and get a political buy-in. And of course, this identification and selection of a national champion to drive the NPHI development is a very critical step in developing a National Public Health Institute. Once the political buy-in secured, national champion is identified, there is also a need to learn experiences from the already established institutions, so that the challenges that the already established institutions faced is not going to be a challenge for the for the establishing institutions. And of course, it needs to be engaged, or the process should engage stakeholders from the beginning. And there is a need to identify which partner is doing what and where, so that we can harmonize the efforts and avoid duplication of resources. Of course, once this NPHI is established, there is a need for continuous assessment and monitoring, so that the NPHI capacity can be built over time. That's the brief findings of the 2 studies that we have from Africa CDC. And thank you for your opportunity. And I'm ready to respond if there are any questions regarding these findings. Thank you. Over to you, Dr. Alex.
Okay, thank you so much, Hassan. Yeah, thank you. Thank you for the nice presentation. And I think you've summarized it well, what the study brought up. And thank you for all those recommendations that should be taken up by upcoming institutions. Now, I think we have, I don't know, Marie, how many minutes are we left with?
We have 6 minutes left. Well, 5 now.
Yeah, we have only 6 minutes left, and I don't know how we're going to address the questions now. I know there were questions on the Q&A. Professor Roma, I don't know whether you saw them. You could actually probably maybe type them very fast. Yeah, we don't have a lot of time now. So I think in the next few minutes, I just want to thank everybody who presented. I know we don't have time for questions anymore, but I want to thank the presenters so much. This has been beautiful. I know this is the first webinar, and we are yet to have many more. But let's continue the discussion as we move forward. The recording is going to be shared, the presentations will be shared. So please send questions to the presenters as and when you feel you need to actually get more information, because we don't have a lot of time. Now, let me just ask Professor Hien, who is the Deputy President of IANPHI African Network, to wrap up this webinar in French, and of course, by also paying tribute to the presenters in French. Professor Hien?
Yes. Alors, thank you, Dr. Alex. Je vais peut-être parler en quelques secondes en français pour remercier aussi les présentateurs pour ces messages qui ont été délivrés. Ces messages très importants venant de l'expérience de Nathalie Mayet et venant aussi de l'expérience d'un Institut national de santé publique de la Zambie et de l'expérience de CDC Africa. Donc, nous avons couvert l'ensemble des sources qui pouvaient nous aider à comprendre le développement des instituts nationaux de santé publique. Et c'est une chance pour nous tous, les managers, les décideurs, les praticiens de la santé publique. J'ai bien aimé le slogan de Nathalie Mayet qui dit « Pensons ensemble » ou « Pensons globalement et agissons localement ». C'est pourquoi je pense que ces webinaires sont très importants pour nous et ça permet d'améliorer la communication à l'intérieur de nos instituts nationaux de santé publique avec des données mises à jour, d'améliorer la communication entre les différents instituts nationaux de santé publique qui sont établis de façon diversifiée et surtout à l'intérieur des réseaux, que ce soit IANPHI, et que ce soit Africa CDC, que ce soit OMS, ainsi de suite, pour que les gens puissent se parler. Donc, Dr. Alex, merci en tout cas pour ce webinaire qui a été organisé et je profite de remercier le secrétariat qui nous a accompagnés dans cette perspective. Merci beaucoup.
Thank you, Professor Hien. I think that brings us to the end of this webinar. Marie, do you have an announcement?
No, nothing to add. Thank you.
Okay, thank you so much, everyone. Thank you for, for attending this first webinar. Please tune in to the next webinar series, which will be organized by IANPHI African Network in collaboration with IANPHI. Thank you so much. Bye-bye.